So the pathway is, this could be a man at risk with a genetic test. It could be a family history. It could be a friend that's been diagnosed. I suppose the big question is whether the role of PSA here in the future. PSA is here to stay, but we saw in the Toronto study where they did MRI in the community in men without PSA, 18% of those men had clinically significant prostate cancer with normal PSAs. So I think there's a kind of question mark here. We've already discussed that the MRI will segment the population into normals and abnormals. Normals are easy, we reassure them that their risk of having clinically significant prostate cancer is very low indeed. Abnormals are easy, they've got an abnormality, and we'll stick a needle in that. There is a grey zone, and I think we need to learn more about that. So like all medical tests, there's a grey zone in the middle. It's not quite abnormal, not quite normal, and we don't quite know what to do there. Right? In Promise, Promise was the big MRI study that was published in January of this year. If it was indeterminate, there was about a 20% risk of having cancer and about a 10% risk of having clinically significant cancer in indeterminate. If you had a lesion, 90 to 95% chance of having cancer in that lesion. So big driver. And I think the other thing about MRI, given where we are, that there's lots of biomarker companies here. Biomarkers change your odds ratios 1, 2, 3 points. MRI, if it's positive, gives you kind of an odds ratio of 26. So it makes you 26 times more likely to have this condition than somebody with a normal MRI. Whereas normally in medical tests it's 1 to 2 times. This is 26 times more likely. Yeah? This is almost unheard of. I suppose there's a question, if the MRI is negative, there's still a little question mark here with the community. So it's taking a while for urologists not to biopsy men, because we've been doing it. And people feel uncomfortable about that. But the precision of a biopsy reassuring a man that he's free of disease is much worse than the MRI. So it's slightly illogical. The biopsy we've discussed, if you have an abnormality in the prostate, and there are lots of stands here that are helping us do that, and that could be an abnormality in the right peripheral zone of the prostate. We can either target that using cognitive kind of attributes. In other words, you say this is in the peripheral zone of the gland, and as long as I stay in the peripheral zone on the right-hand side and I creep along until I run out of prostate, I'll hit it. Or you use many of these technologies that are currently being made available to take you to this target. It's interesting that this conversation on location is now occurring really early in the pathway. It never occurred before. The only time it could occur, and it never did, was after the prostate came out. But there was never any discussion about location. Today, because the MRI happened so early up the pathway, the first discussion you have with the patient is one of location. There's this area on the right-hand side of your prostate that looks slightly abnormal and could be a cancer. We can place a needle into it, and actually if it turns out to be cancer, we can treat it very easily. Right? So you can have that very sophisticated discussion about location, but also a reassuring discussion in the sense that the patient will not necessarily need his prostate removed as a result. Historically, a man went into a biopsy knowing that if that was positive, 1 in 3 chance of it being positive in the old system, he was going to have his prostate removed. So you went into a biopsy with huge trepidation. Your life would change. Now, patients go into a biopsy knowing that actually a selective ablation of that right peripheral zone can be done relatively easily. And moreover, we can tell them that actually from their perspective, it's a bit like having a biopsy. We put them to sleep for a while, for about an hour, they come in the morning, they go home in the afternoon in exactly the same way as they did when they had their targeted biopsy. If that's confirmed cancer and it's clinically significant, and the other thing about MRI lesions, let's draw an anterior horn lesion here, is if we can see it, it's almost certain that there's Gleason pattern 4 within it. So in other words, that it has metastatic potential. Right? So we've already talked about the PIRADS 1, 2, 3, and 4. So, if the radiologist is pretty sure there's a lesion there, there's about a 90% chance that that will be clinically significant. So once you see it, you know what the story is, you know that's going to have some Gleason pattern 4, you know it's going to need treatment. So in a way, the patients are kind of prepared for a focal therapy discussion because all the issues of location have already been discussed.